We have to, and I don't want to use the term ration, but I want to use the term rationalize our healthcare. Because right now, there's not a lot of rationalization in the healthcare system. But what we can do is put as many people as possible into a single pipeline. And that single pipeline for payment would have the same tools for reimbursement, the same codes for billing, and that type of simplification could save a lot in the healthcare system.
Kevin's right on the simplified forms, and we could have done those. The administration through BISHCA could have required those, and still could, that everybody uses the same forms. Some of the cost containments that are in this bill, and it's, I think, important to understand, this board will be setting up what a doctor gets paid for whatever procedure, not what they get reimbursed, but what they get paid, what the hospital gets paid, what everybody can charge and what they'll get paid, what the rate is for the room, what the rate is for the x-ray, what the rate is for a well baby checkup. Now, what's going to happen when someone chooses, as a lot of Rutland people do, to go to Burlington or go to Dartmouth? Nobody knows. But in Vermont, this board is going to fix the rates. And this starts soon. And this stays in place even if the exchange goes away and if Green Mountain Care never comes into existence. We gave the board in this bill the authority to set all of our medical rates.
Studies show that 50% of the factors that determine whether or not we are healthy are related to our own behavior, and Senator Mellon was talking about that earlier. So that would mean you could have perfect care, perfect health insurance, and you still might not be healthy because of not making the right choices. So I think this question of personal responsibility is very important, and I do not see anything in this plan that's going to figure out how to give people better incentives to do that. The other thing I just want to mention is when we talk about the rising cost of healthcare coverage, which is true, you need to understand what's been driving it, and it hasn't been insurance company profits or administration costs. Those are in there. We want to reduce the administrative costs. We do, but those have not been growing. The three things that have driven the increases in costs over the past decade, the things that are making us look at these reforms, are that Vermont actually expanded coverage. We expanded eligibility for Medicaid, we expanded with Catamount, and when people had more insurance coverage, quite rightly, they needed care, probably care they've been deferring. So the cost went up. And the other thing is the utilization of all the high-tech procedures and diagnostics. Now, I think we're right. We have to talk about tort reform and reducing defensive medicine and be sure that you're doing the right tests at the right time. But I also think it's important to realize that our health care system can do things for us now that it never could do before.
And as I understand it, the Vermont healthcare reform is going to take us into an ACO-type organization where there will be global budgets paid to regional hospitals, which will have to make the money last for the year. Physicians, nurses, everyone will be paid from that global budget and will have to make the money last. What this is going to happen for patient care is accessibility is going to become a problem because there's going to be pressure to do less, to make yourself less accessible so you don't spend as many resources to stay under budget. At the same time, we have the concerns that were raised tonight about if we have this perceived free care, we may have an immigration of medically needy, low-income people who may actually put more stress on the system. If people perceive their care as free, there'll be people who will be consuming more or trying to consume more health care. And we may end up in a situation where getting into the physician is difficult. I mean, it's already I have a 2-month waiting period for new patients. And I'm really fearful that if we take this approach that accessibility for patients is going to be difficult, and physicians may be answering to a new master, the administrator, rather than to the patient.
I don't recall any specifics. This is another place where the questions are going to be answered later. And one of the problems with this bill is because we don't have all the questions, it creates a lot of uncertainty. This may all work out in a very good way, but we don't know that now, and it creates a lot of uncertainty. I actually talked to an insurance company executive this morning. She told me that firms that recruit doctors for other states are delighted with this, because it is going to make their job easier to get doctors to not to go to Vermont, to go to other kinds of states.
I talked to some internists from Rutland Regional Medical Center. They had been to a small conference up at Fletcher Allen in Burlington. This was back in April timeframe. There were 16 participants at the conference. Out of their own accord, they asked, how many of you are seeking licensure in another state? Of the 16, all 16 said yes. How many of you are seeking jobs in another state? Of the 16, 14 said yes. I received emails from most, if not almost all, of the urologists in the state of Vermont. All but 2 said in the emails, if you pass this, I'm going to retire or leave. It is a huge concern.
I received a letter from Mel Boynton, who I'm sure everybody here knows. It reads as follows: please vote no. I've seen the bill and Shell's report. There are many omissions in the consultant's report, and savings he reports will not be a reality. Jim, unfortunately, due to these circumstances, I, as chair of the Department of Surgery at Rutland Regional Medical Center, have recommended that all surgical specialists under the age of 55 at Rutland Regional Medical Center to get active medical licenses in other states. I have an active license in Florida, and I'm looking at Michigan and New Hampshire. We don't want to leave, but we need to be ready to depart promptly to a state that values our services. I need to seek value in healthcare, but this system will not provide that.
If we go to Green Mountain Care or anything like what Green Mountain Care is talking about in terms of everybody being in it, I do not think it will work unless everybody is paying in it. Whether it's a payroll tax or an income tax or sales tax, everybody's going to have to pay in it. Even people who do not use it, like people on TRICARE or Medicare or self-insured plans. So, and I think that's pretty much what Wendy's analysis showed. Right. She used the payroll tax and we don't know what it's going to be. So this is one of the big problems, because I think there will be a legal challenge. I think there is a reason for thinking about a system that includes everybody, but Vermont is too small to do that. We're not a nation state. We have too many fragmented things. But I think there is a really big issue, A, as to whether you can force the ERISA plans to pay into it, and B, whether this system will work if you don't do that. And amendments were introduced to try to exclude those plans, to try to address these issues, and they were defeated. So this topic was completely discussed, but the people who were pushing this bill did not want to address it. So that's why it isn't addressed.
The cost, $3. We say it's going to be covered, $300. This is the cost of the service. Medicaid pays $1, leaving these other $200 out for someone else to pay. It's a cost shift. 1/3 of Vermonters are on some type of state program. When you get 1/3 of them paying $1 for something that's cost $3, those $2 have to get spread among the rest of them. So now, instead of me paying that, what would have been $3, I now have to pay my own $3 plus the Medicaid buck.
You're out of money.
So now I'm paying, yeah, but it's Kevin's money, so.